السلام عليكم. Shukran to Dr. Mohammed in Alpha Care for inviting me to come here. It's a huge pleasure to be here with you. I've been enjoying a lot Egypt. It's my first time here. So thank you so much for having me here. I will share with you some of the research we're doing in Portugal regarding preparing patients for cancer surgery. So I'm coming to speak about scientific questions that may help. Scientific questions we are trying to solve that may help to improve clinical practice. So I promise we won't discuss clinical issues as the previous discussion, very interesting, but we will not do that. But I will share what we are trying to do to improve our clinical practice at Porto. So first, what is the challenge we are facing, and I believe you are also facing here? When a cancer patient goes to surgery, the success of the surgery used to be measured by the perspective of the surgeon, in the way that if he removes the entire anatomic piece, that would be considered a successful surgery. But it is changing, fortunately, and now we must pay attention to the perspective of the patient. We want the patient to recover, to be on his best shape after he is coming from the operatory room. So we need to take care of these aspects. We want the patient to be adequately treated, but to recover his functional independence as much as we can. We want him to return to his physical and psychological state as much as we can. We want him to go back to work as fast as he can and to have a very good quality of life. So what is impacting the patient to enjoy these outcomes? We have a major issue, which is post-operative complications. And post-operative complications, no matter how good the surgeon is, they can occur. And they are the major barrier that we identified who limits or who is responsible for these other outcomes, like making the patient to stay for a long time at the hospital, making the patient to need critical needs, making the patient to need to be readmitted again or to be again submitted to other surgery to repair something, or even the patient may suffer from any delay or postponement of the subsequent treatment like chemotherapy, and therefore it may limit the chances of cure and survival. And overall, this will impact, it will input a huge financial burden to all the healthcare system. So we want to prevent this. And despite all the improvements we have seen during the last years in terms of anesthetics, in terms of surgical techniques, in terms of perioperative care, you can see that the burden is still high and post-operative mortality is still an important issue. Post-operative complications are still high. And in a specific setting of cancer, you can see that depending on the cancer and on the surgical approach, but mortality ranges from 2 to 10%. And post-operative complications, they range also from 20 to 50%. So it's a huge thing that we have to deal. And this is a problem, also a very important problem here in Africa. This is a very nice study published a few years ago by Dr. Bacardi, and he shows that Africa, despite having lower risk surgical patients, they have almost the double in terms of post-operative mortality due to post-operative complications. This is a major issue. In our reality, so this is in our hospital, this is data from the cancer setting from the stomach. This is data from the Portuguese Institute of Oncology in Porto, where I performed some of this work. And this is where we started interesting on this thing and to manage this issue. In 2019, we did the audit, and we saw that, this burden. So 12% of our patients are re-hospitalized. 9% are reoperated. 53% of our patients suffer some kind of complications, and 20% have major complications, so important complications. And even mortality, it is an issue also for us. So we need to do something. And why we need to do something? Because a tsunami is coming in terms of surgical needs that are increasing. This is data estimations for cancer surgeries. So we expect that due to the demographic changes of the population, we are all getting older, and fortunately we are living longer. So we will get more cancers to treat. So they are estimating that there will be a huge need of cancer surgery in the next few decades. So if you apply the 20 or 30% of postoperative complications, you'll see that the number will also rise very significantly. And the second concern is regarding with the profile of the cancer patients who will need surgery, because it's also changing. We are focused on this major segment of the population, the older ones, who usually are less fit, they have a lower physical capacity, they have accumulated comorbidities, they have a huge amount of other risk factors, and overall, this put these patients in a huge danger. They have a lower physiological reserve, and they have, of course, a greater risk of poor surgical outcomes. So there comes a challenge to the surgeon. So Shakespeare had this question, to be or not to be is the question, but the surgeon, in face of this reality, will ask to operate or not operate. This is a really important question. He will look to the patient, he will see a frail patient, old patient, comorbid patient, and he will have to measure the benefits and the harms of the surgery to make this decision. How can we help the surgeon to make a better decision? We are concerned with improving perioperative care. And this is just an opinion paper that we wrote a few years back, where we identify some issues that we can do on the preoperative level, intraoperative level, and postoperative level. But for the purpose of this lecture, I will focus on the preoperative level. So we are working on two things. We are working on improving the risk stratification of our patients, and after stratifying our patients, we want to optimize them. We want to put them in shape for surgery. So I will share with you some of our steps regarding these two issues. So the first one is regarding to optimize stratification for surgery. Why it is important to stratify before going to surgery? Because this will help the surgeon to make a better decision, to decide if this patient has ability to tolerate or not the surgery, and therefore we can invest on the surgery treatment. It's also important to identify, okay, the patient is, he can go to surgery, but he has this issue and this issue and this issue that must be optimized first before he goes to surgery. And we want to, that the ideal risk score should also inform us not only that this patient is at risk, but what is contributing to this risk. And most importantly, can we modify, so are these variables that we can modify and therefore reduce the risk before putting this patient to surgery? So we've been we've been comparing several risk scores. There's a lot in the literature you can use. Some are more easy to apply, others are more complex. We did our tests using very basic surgical risks. We used one of the American College of Surgery and the PIPOSUM. And when we compared the use of these two risk scores in the same population, we saw that they have a very, very poor agreement between them. You can see that they only agreed in 21% of the patients as being high-risk patients. So this information is given to the surgeon. How will he decide? I decide, and I will go to the ACS, or I decide I will go to the PIPOSUM. He's very confused because this is not good. Poor agreement. So we think that the poor agreement between these score risks is mainly because they are developed in populations that have different features from our own. So we believe that we need to optimize these surgical scores so they can be more accurate and more specific to our clinical population, to the features of our clinical population. And for instance, we used multivariable analysis, and we mixture all variables from all the models we had, the predictive models, and we, on our specific population, we identify that by using age, gender, and physiological PPOSM and ACS serious complication rate from those instruments, we could improve significantly the discrimination of a high-risk patient or not. So when we compare the performance of this new, let's say, algorithm, it had a higher area under the curve than these two risk instruments. So we are now using this one in our hospital, but we want to improve it more. We want to do it to be more specific and to be more informative regarding the physiological reserve of our patients. So we are now working on this. We are trying to, we know this relation, so we know that cancer treatments are very impactful in a negative way to our physiological systems. We know that our tolerance, the tolerance of our organism is dependent, is very important for the body to develop complications or not. And we know that there are a lot of physiological variables that are determinant for our physiological reserve. So we are now trying to improve our models by studying what is the impact of these physiological reserve metrics in our patients. So we are measuring physical activity, physical fitness, sarcopenia, frailty, psychological distress, nutritional status, and so on. And we have some preliminary data that I will share with you, and I will always acknowledge the students that are working with us to do this research. So this is our first exploratory study, and we wanted to assess the impact of neoadjuvant chemotherapy on the physiological reserve. So this is chemotherapy before going to surgery. And we recruited patients with locally advanced gastric cancer who were eligible to do this treatment with FLOT. So FLOT is now in Europe considered the best standard of care to these patients. It's a combination of 4 drugs, and the patient does 1 cycle every other 2 weeks, 4 cycles before surgery, and 4 cycles after surgery. So it's almost 2 months of treatment. This is the general characterization of our sample. So gastric cancer impacts mainly men. They're not very old. They are around 58, 60 years, so they are relatively young to support these kind of treatments. And what did we saw? We saw that chemotherapy, and this regime in particular, increased the incidence of probable sarcopenia by 20%. So after 2 months of doing this chemotherapy, we had 20% of our patients developing probable sarcopenia as assessed by the hand grip strength test. So this means that these 20% patients are going to surgery with a major risk factor, which is sarcopenia. Next, we also assessed it by questionnaire. So you have a lot of questionnaires to assess physical activity levels, and you can then stratify the patient with a low level, medium level, or a high level of physical activity. We used the IPAC short version, and we saw that after chemotherapy, more than 30% of our patients decreased the levels of physical activity. And we know that lower levels of physical activity is also a major risk factor for postoperative complications. We measure some aspects of body composition and physical fitness. And as you can see, these general measures, like they didn't change in terms of body weight, they didn't change in terms of BMI. But if you assess skeletal muscle, for instance, by measuring the calf circumference, you see that the patients had a significant reduction in the circumference, so suggesting they are losing skeletal muscle. They are gaining weight in terms of fat, but they are losing skeletal muscle. And this is another major risk factor for poor postoperative outcomes. Regarding physical fitness, sorry, this is the colors change a little bit. But on your left side, you will see the ones who had to postpone their treatment. And on the left side, you will see the two bars who represent the ones who did not postpone their treatment, their chemotherapy. So we stratify the patients by those who need to postpone or did not need to postpone chemotherapy. And we observe that the ones who needed to postpone the chemotherapy, they have a lower baseline physical fitness as assessed by the hand grip or by the 6-minute walk test, so aerobic capacity. This was observed again when we stratified the patients by the ones who had to decrease the amount of the drug or not. So we saw exactly the same. The ones who had a poor physical fitness in baseline were the ones who needed to decrease the volume of the drug that was given for the treatment. So our patients are reaching the surgical period in a very poor shape, with accumulating several risk factors that will increase the chances of poor postoperative outcomes. In our second exploratory study, we want to see, okay, how does the preoperative physiological reserve affects postoperative outcomes? So again, now we assess it in gastric patients, again, with adenocarcinoma, submitted to major surgical treatment, and we assessed several surrogate markers of the physiological reserve. Sorry. Again, this is the general characterization of our sample. So again, the age is around 60, so relatively young people, mainly men's. A significant part of them were already pre-frail or frail at the beginning, and the majority, 70%, around 70% were directed to surgery, and 30% had to do neoadjuvant chemotherapy before going to surgery. And now we assessed physical activity more objectively, so we use this device that measures physical activity, and we saw that 50% of our gastric patients, they don't comply with those World Health Organization guidelines about the 150 minutes of moderate to vigorous activity. It's even less in cancer patients, but I will just focus on the gastric patients. Regarding to the surgical burden of these patients, you can see here that 41% of our patients had complications. 21% were major complications. And you see that we had issues with hospitalization, readmission, reintervention, and mortality. Not acute mortality, but long-term mortality. For instance, until a 2-year follow-up, we already have 23% mortality, so it's a huge thing. And then when we try to see how the baseline physiological reserve indicators, they relate with these outcomes, we observed this. So the number of frailty deficits, so we use the Freed frailty test. It has 5 physical tests. So you can have 1 deficit, 2, 3, 4, or 5. The more you have, the more frail you are. And we saw that the number of deficits, it's related with need hospitalization. We saw that having a lower physical fitness in baseline, having a lower physical activity in baseline was also associated with the need of being readmitted. And when we look to our patients who died, we saw that more than 70% of them were already frail at baseline. Okay, so we have a lot of things to improve if we want to change this thing. We also saw that there was a significant association and correlation between the amount of steps. So we now are just focusing on trying to explore the physical fitness and physical activity of the ones who died, so those 23%. And we saw that the time of survival was related with a better shape in baseline. So the ones who died later had a better physical fitness and physical activity levels in the baseline. And you can assess this very easily in the clinics with very easy tests. So, okay, we have a problem. we know several risk factors that are present in our patients in the baseline and can interfere with post-operative outcomes. Now the question is, can we change this? Can we optimize these patients? Because all these things I show you are relatively easy to change if we have time. We have several protocols that show that we can improve sarcopenia, you can improve frailty, you can improve body mass. So can we improve our patients before they go into surgery? And this has been termed rehabilitation, so preparing patients for surgery. This is our challenge. If we prepare people to support this kind of stress, huge stress, why don't we lose time and invest also in preparing our patients for surgery, put them fit for surgery? So rehabilitation was brought to the oncology field by this physician, Professor Franco Carli. He's Italian, but he works in Canada. Rehabilitation was previously used in orthopedics and cardiac surgery, and since 2010, it's becoming more used in the oncology surgery. And he is considered the father of rehabilitation in oncological surgery. So what is rehabilitation? It's an intervention that you apply to a patient immediately after diagnosis and before the first cancer treatment. It implies a comprehensive assessment, so a medical assessment, nutritional assessment, psychological assessment, and physical assessment. Again, it's a multi-professional assessment team. So people here cannot work in silos, they cannot work isolated from each other, they should work together. And after identifying the needs, so the impairments, we should decide a tailored intervention to improve our patients. And we have these 4 pillars that are considered essential for rehabilitation. We have exercise program that should be tailored. We have a nutritional intervention that should be tailored, psychological intervention, and of course, medical optimization to optimize risk factors, anemia, that's also present, it's very important, so optimize patients. And ideally, we'll have time to improve the physiological reserve and therefore reduce post-operative complications. So this is the theoretical model. On the pink line, you see the normal people who have the usual care. So they reach the surgery, they have the surgical stress, and then their functional ability decreases significantly. And they will take time to recover, or they eventually will not recover their baseline levels, okay? And on the green line, you have the ones who hypothetically did optimization before surgery. So you improve their ability, their functional ability, then comes the surgical stress, it will decrease, but not that much as the other one who did not have the intervention, and the recovery is hypothesized to be faster, okay? So this is the hypothetical model. But does it work in real world? This is just one study from Professor Franco Carli on esophagogastric cancer patients. So he randomized these patients to the standard care they had in Canada, and on the other arm, they give the standard care and they did this rehabilitation program. It was a home-based program focused on aerobic training, walking 3 times per week during 30 minutes, moderate intensity. And they also gave a nutritional program according to the specific needs of their patients, okay? So this was their program. And what did they saw? They saw that the ones who did not, or who did the usual care, they decreased their 6-minute walk distance during chemotherapy, and they decreased it even more after surgery, okay? And you can see that even after surgery, 82% of the patients, they had a poor functional fitness in comparison to preoperative levels. What about the ones who did rehabilitation? You can see that they were able to improve functional capacity during chemotherapy, and they maintained their physical fitness even after surgery. Even 52% of their patients were better after surgery than they were before surgery. Now, the second question is, okay, we can improve physical fitness, apparently, before surgery. But does this translate in better clinical outcomes? Does the physical fitness improvement translate in less complications? This is the question that is now becoming explored, and we have some data from systematic review meta-analysis that combine surgical patients from different clinical settings, not only cancer, but other clinical settings too. And what does the evidence tell us until now? Yes, rehabilitation reduces significantly overall complications. It reduces particularly pulmonary complications, which are the most prevalent on our clinical setting. And inside the pulmonary complications, it seems to improve specifically pneumonia, which is also one of our most important enemies, let's say. So it seems to work. It seems to have time to improve physical fitness, and this improved physical fitness seems to result in better post-operative outcomes. But, as I told you, this is a combination of studies from different surgical settings with different underlying diseases. We also did a systematic review focusing only on gastric cancer patients with high risk for surgical complications. And we defined high risk as the ones who had an age above 75 years or who were diagnosed with frailty. And what did we saw? We saw that the ones, so the high-risk patients who were submitted to rehabilitation, they had a significant reduction in major complications, and they had, on average, less 3 days of hospitalization. So this means saving money. It's important. Not only saving the patient, but also saving money for other things that are also important on our healthcare system. But there are currently a huge amount of gaps, and gaps means opportunities for who like to study these things and to contribute to the clinical practice. There's a huge publication bias because the majority of these studies come from Canada or UK, where rehabilitation is very well established. So now we need external validation. We need to other countries with different facilities also to test these things. There's also a clear bias to certain types of cancer. For instance, colorectal cancer, esophageal, and lung cancer are far the ones that are more studied. So all the others need to be tested. And there are other things to be tested, like unimodal interventions, multimodal, home-based, supervised interventions. We specifically are interested on assessing the impact on postoperative complications by doing a randomized control trial with a sample size that was specifically calculated to address these outcomes. Because the majority of the studies that have been developed so far now, they were not powered enough to respond to the question of postoperative complications. And we are doing our trial to answer that. And also, it's also a very interesting question to know what is the impact of rehabilitation on tolerance and efficacy of chemotherapy. Because there are some preclinical data from animal studies showing that the animals who run while receiving chemotherapy, there's an additive effect and the size of the tumor is even lower. And when you see the tumors, you see that they are more perfused, they are more inflammatory cells, natural killer cells who are very nice to kill tumor cells. So there is this hypothesis. Does physical exercise also improves the size reduction, so anti-cancer drug efficacy in humans? We are also very interested on exploring this. And of course, what are the molecular mechanisms we have underlying this? So we were very fortunate to be conferred by a grant from our government to explore some of these questions. And this is our randomized control trial. We call it PROTECT. So it's rehabilitation to enhance cancer treatment. And we are focusing on gastric cancer patients who have locally advanced disease. So they are eligible for neoadjuvant chemotherapy, and then they go to surgery. Our primary outcome is to see if prehabilitation, home-based prehabilitation, a structured planning or a non-structured planning is equally effective on reducing post-operative complications. And as secondary outcomes, we have several, so changing physiological status, psychological status. We are collecting tumor samples to see if the intervention changes something in the tumor in terms of tumor regression and tumor microenvironment. We are collecting samples from urine, blood, skeletal muscle, adipose tissue to see how chemotherapy impacts these tissues and how the intervention models the remodeling of these tissues. I'm going to share the preliminary data with you. So this is our study design. Patients are recruited on their first visit at the the Portuguese Institute of Oncology. If they have the criteria that we need, they are invited to participate in the study. They are screened for contraindications to exercise. And if it is okay, they sign their formal consent, and we explain them the intervention. We are a very huge team of physicians, physical therapists are also working with us. The physiatrics and the physiotherapists, they are the responsibles for the screening and for the explanation of the intervention. So they teach the patients what they should do at home. So then they are randomized to a non-structured or structured intervention. They go to home, they start working, they do their chemotherapy treatment, they do their surgery, and then we assess them at multiple times. Before treatment, after chemotherapy finished, and after surgery. What is our program? So on this non-structured program, intervention, we are giving patients the usual care that they have in the hospital, and in addition, we give them a book with small instructions on how to accomplish 150 minutes of physical activity per week. We also give him this physical activity monitor just because we want to collect data. But you don't need to use this kind of technology. You just give them the diary. They can register when they do the activity or not. And on the other group, so the structured intervention, again, we do the usual care, and then we give them specific instructions about aerobic exercise, how much per week, how much time, what is the correct intensity. We give them a book with exercises they should do at home with elastic bands or with body weight. And we also give them this device to train their inspiratory muscles. So they do a respiratory assessment to determine the maximal inspiratory pressure, and then we prescribe inspiratory muscle training according to this test. What is our data until now? So this is very preliminary because we only started this study 1 year ago, and it's a long study, so we follow patients for almost 8 months, so it takes a long time to collect data. Until now, we have recruited 50 patients, 30 were allocated to some of these groups, and 12 already ended the study. So we have almost 4 on each arm. This is our preliminary data regarding functional capacity. So you can see that the group patients who did the intervention, structured or non-structured, they were able to maintain their physical capacity, here measured by the 6-minute walk test, after surgery. And just to compare let's say the magnitude of this effect, I had this pink line, which means patients who did not want to participate in the study, but they allowed us to follow them. And you can see that the intervention works. Even if it is structured or not, it works against doing the usual care. Screen failure. Screen failure. We call it screen failure follow. So they are screen failure follow. Yes, they are like our, because we think given the level of evidence, it would be unethical to don't give exercise or not recommend exercise. So we give the opportunity to exercise, in a structured way or non-structured way, and the ones who don't want to participate, we ask them to be the control group, okay? And I'm not showing the data, but we have preliminary data that this resulted already in a 10% reduction in major complications. So it's a simple thing that can be used and significantly improve the health of our patients. So sorry. This is my team, so I want to acknowledge all my team who is working with me on this project. On the left side is Professor Lucilara Santos. He's a surgical oncologist from this hospital. He's African. He's from Angola, so he works in Portugal, but he goes a lot of time to Angola to do a lot of training to surgeons, to physical therapists, and so on. And he's enthusiastic of exercise to prepare patients for surgery. And on the left side are all my previous or actual or current master and PhD students who are working on this project with me. So thank you so much for them. Also acknowledging the funding agency, otherwise we won't be able to do this kind of research. And finally, well, I would like to say that you are all welcome if you want to visit Porto on vacations or working. It's also a nice city to see. It doesn't have so many old monuments like you have here in Egypt, and I had the privilege to visit, yes. So shukran. For giving me the opportunity to visit your wonderful country and for meeting wonderful people while I've been here. Thank you so much. It was a huge pleasure.